treatment of breast cancer. We all agreed that there are three types of primary breast malignancy. Lymphoma, just treatment is chemotherapy. Sarcoma, treatment is local control, either wide local excision or mastectomy. Quite often it does not need chemotherapy unless there is metastasis, proven metastasis. But the carcinoma that arises from the epithelial tissue, the invasive ductal carcinoma or the invasive lobular carcinoma or ductal carcinoma in situ, their treatment is different. Let's talk about the main types of carcinoma, the carcinoma in situ and the invasive ductal or lobular carcinoma. Ductal carcinoma in situ is a true local malignant disease. All it needs is good local control by either just surgery or surgery plus radiotherapy. It does not need nodal assessment because by definition it has no ability to metastasize, to spread. But sometimes we have to do a sentinel node biopsy while we are locally treating DCIS. When is that? If you are doing mastectomy, because we can find incidentally after the operation a focus of invasive. We need to take the patient back to theater to assess the lymph nodes. There is no breast tissue to inject your material. You'll be committed to clearance. So when you are doing mastectomy, you have to do sentinel node biopsy for a DCIS. Also, if it presented as a lump, because quite often it will have had some micro-invasive transformation here, and you always have to assess the lymph nodes. So in this case, you also do sentinel node biopsy. Right, this is local control. So sometimes you assess the ER status, and if it is positive, you might give her prophylactic tamoxifen on the long term. But surgery is quite often curative for DCIS. Let's talk about the invasive, the main type of tumor we face in our practice. Invasive carcinoma, it could arise from invasive from the ducts, from the lobules, from many mucinous carcinoma, medullary carcinoma, squamous carcinoma, papillary carcinoma. All are treated the same because they have, by definition, the ability to spread. The local control, just like DCIS, is not enough. You quite often need to give some adjuvant, complementary, extra safety to guard against any chance of any metastases. So what are the other options above surgery? You have the chemotherapy, you have the radiotherapy, you have the hormone therapy, and you have the monoclonal antibody, the Herceptin and the Perjeta. Who does need radiotherapy? Any patient who's had breast conservation, it's mandatory to give her radiotherapy to sterilize or stabilize this breast. So the old saying, mastectomy equals wide local excision and radiotherapy. But sometimes you do radiotherapy, you do mastectomy, and you still give radiotherapy if you have lymph node metastases. So the indication for radiotherapy is either breast conservation or any node positive disease will also have to have radiotherapy, even if you've done mastectomy. Right, who does need hormone therapy? Well, about 70 to 75% of all women breast cancer will have ER positive signals. What does that mean? Means her tumor relies on her estrogen as a fertilizer to grow, to continue to grow. So it is something we do like, but we will also give them hormone therapy, at least 5 years compulsory and 5 extra years by choice and discussion with the patient. Who does need monoclonal antibodies, Herceptin or Perjeta? The HER2 receptors will be assessed. They are about 20 to 25% will be positive. It is a bad signal. It's a protein on the surface of some of these cancer cells. In this case, if we find it and she does need chemotherapy, we will also give her